So just some background on myself and kind of what this presentation is. I'm not a research fellow or anything like that. This lecture came about because I got to meet Mary Alice and Tony and their son, James, and I told them what I did what I always do when I do a developmental eye exam on a child, or an adult for that matter. And I just explained to him what I test for, why I test for it, what the results were. And obviously, it was some information that they'd never been given before. And so the point of this lecture is some of this you may have heard this before. Hopefully some of it's new, but it's kind of the background on why we do what we do. My goal for you guys is to give you practical things that you can do Monday morning that will, a take-home thing from this of what can I do for my child, or just make an actual, be able to do something for your child or for yourself who has nystagmus. I have sat through my fair share of lectures, and one of the things that always bothers me is a lecture that I just think, where are we going with this? And I had a professor one time talk about launching airplanes into the air, and you just think, is this airplane ever going to land? Is she ever going to make a point? So I will tell you as we go through this, I'm going to launch a lot of different airplanes. We're going to talk about vision. We're going to talk about development. We're going to talk about functional testing, all that kind of stuff. But the hope is at the very end, all the planes will land, and I will make some sense out of all this. So let's start by just talking about the 3 O's. You guys know who all these people are. Optician. This is more to get your vocabulary straight, but an optician is somebody who measures patients for glasses. They make your glasses. Most ophthalmologists or optometrists have opticians who work for them. They're the ones that actually make the thing that we prescribe for a patient. So they're critical to, it's funny, I tell patients, I'm like, I prescribe it, but the person who actually makes it is the one that you need to see. And so having a good optician is key to getting your patients what they need. Ophthalmology, you are all aware of what ophthalmology does. They are surgeons. And from what I have gathered, now I'm in Louisiana, very, very, very strong ophthalmology state, very weak in developmental optometry. There's 2 of us. So the patients that I get have only seen ophthalmology. They're coming to me because they've seen ophthalmology for years. They're looking for a second opinion. So I don't think they're the enemy. I think we do things very, very differently. And so it's just another perspective. I have a lot of patients who have both. You can have an ophthalmologist, but you might want to have a developmental optometrist also, because we're going to look at your visual system differently, okay? Then you have an optometrist. We're eye doctors also. I mean, we don't do surgery. We can prescribe. We treat ocular diseases. We fit glasses and contact lenses. There's a lot of things that we're kind of on the front lines of vision care. And then within optometry is a sub-profession called developmental optometry. Has anybody here ever heard of a developmental optometrist? Okay, good. Then hopefully by the time we leave here, you'll feel like you understand what a developmental optometrist is. But basically, I'm an optometrist. I just have additional training in how vision develops and visual problems that can affect a person's ability to read, learn, and do well in school. And the reason we use the term developmental is this. The hierarchy of motor development. This is not something I was taught in school. This is something that I learned when I actually started seeing real patients. So in school, we were taught nothing but the ocular motor part of things. And again, we'll go through all that stuff. And then I started seeing real kids and real patients, and the rest, it's not 2 eyeballs that rolled into the office. There's a body attached to it. And so looking at other things. And so the point of this slide is to show you that while I treat ocular motor, or vision is just a good catch-all term for it, but I wanted to keep the motor part of it. I treat the vision problems. The things that develop first are your gross motor skills, which we will review. Then after that area of development, you transition into fine motor development, things like handwriting, pencil grip, that kind of stuff. And then after those stages of development, you then get into your ocular motor development phase. So if I find issues with ocular motor, it stands to reason developmentally there may be weaknesses underneath that. Not always, but it's something that I feel very strongly needs to be ruled out, which is what we test and screen for when we do functional vision evaluations, is on most kids and adults also, depending on the conversation we have in testing. I can screen your fine and gross motor skills, see where they are, and then decide where do we need to start treatment along with your ocular motor skills. Any questions on this? By the way, this will sound like a lecture. It's not. If you have questions, please raise your hand. Okay, so The reason why, obviously, I think vision is so important, it is the most dominant sense. It's connected to every cortical lobe and structure of the brain. There are 35 areas of the brain that are totally involved with the processing of visual information. And 70% of the sensory information to the brain is visual. There's more area of the brain dedicated to vision than any of the other sense modalities combined. So vision influences everything. So it stands to reason, if you have issues with vision, whether it's nystagmus, strabismus, other type of vision problems, it very likely can have an impact on your development. Likewise, if there are issues with development, it can have an impact on your vision. So hence the term developmental optometry. We're looking at the whole spectrum of development to see where are there weaknesses, where is there room for improvement. I use the term with families, vision drives development. The example for that is a child will see something that they want, and when they're a month old, there's really not a whole lot they can do about it. But as their vision improves and as their motor development improves, they're going to figure out a way to get to whatever it is that they want, whether they grab it and they bring it to the mouth, or they figure out how to roll to get what they want to, get to crawl to whatever they want to. But vision is what is driving all of that development. I'm going to go through just the highlights of developmental milestones. And the reason I put these slides in here is I don't want you to think that I'm saying that patients with nystagmus will have developmental delays. I don't mean that at all. It's more of just hitting the highlights so that as you're going through and thinking about if it's your own child, with or without nystagmus for that matter, did the child develop the way that they should, knowing that vision is what drives development. So for starters, from birth to the age of about 5 months, we are incredibly farsighted. We have a lot of astigmatism. Babies have very poor vision. They can see about this far in front of their face. At about 6 months, a lot of that farsightedness and astigmatism starts to reduce, and that's when you'll see babies start basically look across the room or look further than just looking at your face. You'll see during the first 6 months of life, the kids start holding their heads up. They'll lift themselves up with their arms. That's when you'll see them roll from back to side, or from their back to their side or from their front to their side, not a complete rollover. And that's when they begin to grasp and obviously bring things to their mouth. At 6 months, this is when a child has normal vision. This is when you start to see them sit up, and this is when they'll start to roll over. Between 6 and 12 months of age is when we recommend a child's first eye exam, regardless of anything. Any child between 6 and 12 months of age needs to have their first eye exam, and that's with an eye doctor, not at the pediatrician's office. It's not the same thing. Anyway, between 9 and 10 months of age is when a child starts to crawl. Crawling is a really controversial subject. I don't know if you guys are aware of that, but discussing whether or not crawling is necessary as a milestone is huge. I personally think it's a really big deal if a child crawls or not. And I have a lot of parents that tell me, my child skipped crawling. We went from, sitting to walking. Well, what happens is when you learn to crawl, you learn to cross your midline. There's this imaginary midline in the middle of the body. And when you crawl, you've got your left front doing one thing and your right front doing the other thing. So your arms are doing opposite things, just like your legs are doing opposite things at the same time. These are skills that we use in our life to be able to move in opposite directions. Think about riding a bike. You've got your legs doing opposite things. And so for my own child, I will tell you, I have 3 kids. One of mine, when he started the phase of learning how to crawl, had a lot of trouble, and that's when I knew I'd suspected some issues with development, but when it came time for him to learn how to crawl, he could not figure it out, and so that's when he landed in treatment, and we'll talk about treatment for that. But I think for me, crawling, if I hear a parent say, my child didn't crawl, isn't that awesome, they skipped that step, I think, no, we need to go back and work on that. And then fine motor, at this age is where they develop the pincer grasp. This is the thumb and forefinger coming together that will eventually turn into the pencil grip that they'll need for good fine motor skills like writing. At 12 months of age, child's going to stand. They're going to start walking along furniture. Vision is pretty much the same after about 6 months, 6 to 12 months. Vision is kind of leveled off as far as how well a child can see. At 18 months, this is when we expect a child to walk alone, jump with both feet, climb stairs on a rail. Have you guys seen that video that went around Facebook about a month ago of the baby getting glasses for the very first time? Did you guys see that? Do you guys know what sent them in for the eye exam? The baby wasn't crawling, which I just thought, oh my gosh, somebody got it right. Somebody told this parent that because your child's not crawling, it's time to get an eye exam. And the video is just so powerful because obviously you can see the benefit that the child has by putting glasses on. But back to that idea of vision drives development. She couldn't see. And so if she can't see, what's the point of trying to move across the room, And so again, the idea is if you can help a child see, and we'll talk about, especially kids or anybody with nystagmus, what kind of correction we give patients. It was talked about in the vision therapy lecture and how sometimes patients with nystagmus are undercorrected or left alone as far as glasses are concerned, and that's not appropriate. They should be fully corrected, and we'll come back to that in a little bit. Anyway, back to the gross motor development. This is where you'll see kids walk. They start jumping. They'll climb up and down stairs, and then they'll start building blocks of towers. They'll start to throw a ball, and they'll start to feed themselves. By 2, they can run. They should be more coordinated, and they can start to build a tower of 6 cubes. By 3, so first eye exam is between 6 and 12 months of age. Next eye exam is at 3. This is probably my favorite age to do an eye exam because you can get a ton of information out of a 3-year-old if you know how to get it out of them. But by that time, you can get an accurate measure of their color vision. You can measure their depth perception. You can begin to test their converging and focusing abilities, which we'll talk about what I mean by those in a minute. They begin to track, which is a pre-reading skill that they need. And then you start to see them be able to copy a circle, drawing a person, other things like that. This is all stuff that we test when we're doing our functional vision evaluations. So again, just kind of running through and highlighting all this stuff. By 4, the big thing is they're able to skip. They can copy across, and this is when they begin to dress themselves. I've had parents, when I talk to them about how coordinated their kids are, they'll talk about how their children struggle with doing buttons and other things like that. And if you've got a 6 or 7-year-old that's struggling with that, that is a red flag for a fine motor delay. By 5, they're skipping, they're hopping, they can dress themselves, usually in what you don't want them in, but anyway, that's another battle. And then by 6, I usually see kids at 3, and then I want to see them again about 5 or 6 years of age is the next one. And this is where developmentally your vision develops from birth to the age of 6. So I want to see you in there 3 times to make sure by the age of 6 everything is developed the way that it should. And we check their tracking ability at that point, and we check on converging and focusing. And again, I'll talk in more detail about what I mean with those skills. Okay, so any questions on developmental milestones? Okay, so next we're going to talk about the definition of vision. Okay, you guys may actually know this. Most groups that I talk to don't. Does anybody here know what the definition of 20/20 is? We hear it all the time. We hear 20/20, we hear 2200, 2100, and we as eye doctors throw that out as if you guys know what that means. And there's a lot of people who have a misunderstanding. You may know what it means, but I guarantee you, if you're talking to a teacher, a principal, friend, possibly the pediatrician, they probably don't have an understanding of it like you may. So does anybody here know what the definition of seeing 20/20 is? What is it?
Isn't it like the first number is the standard of which you should see from a 20-foot distance?
Right.
Character.
Right.
And then second is the distance in which you personally see.
Right, exactly. Okay, y'all did not know that? Okay.
I have a fun fact if you want.
Okay, go for it.
So apparently baseball legend Ted Williams, who played for the Red Sox, his vision was 27. So
oh, really?
They said when he was sitting in the dugout, he could read like the telephone numbers of the ads on the outfield wall.
Yeah. That speaks to his neural capacity, because when we say 20, that's what it is. Well, 20 is the smallest size that a person can see from 20 feet away, and we'll go into that. But the human brain can only perceive a certain size from a certain distance. Pilots can get to 2015 because their brains are capable of seeing 2015. So Ted Williams could get to 27. I mean, I don't even test for that because you have to have the brain that can do it, and I don't get a lot of those brains that come into my office. So anyway, so one thing that I always want to talk with parents about is this talking about 20/20, especially if we're doing accommodations for a child with nystagmus, or we're talking about whether or not a patient can legally drive or other things like that. We keep coming into talking about this 20/20, and do we even know what it means, okay? So what 20/20 means is the top 20 means you're looking at the chart from 20 feet away, and then the bottom 20 means that's the size of letters that you're supposed to be able to see from 20 feet away, okay? We're going to do a demonstration here in a second. And where else? I'm going to have you do me a favor. Just hand these out. Ignore her while she's doing this, but I'm just going to hand those out to people. Okay. All right. So 20/20 line is right here, okay? If you can't see that, you can go up to the bigger line. Can everybody see, if you're all the way in the back, can you guys see that? Okay. What I want you to do for this part is you're going to partner up. We're going to do a demonstration, okay? So find a buddy. And what you're going to do is, for the first part, you're going to read out loud whatever row of letters you want to. It doesn't have to be 20/20. It can be 20/30. For argument's sake, just to get the information out there, you can pick whatever row you want. And as you read the letters out loud, I want you to pay attention to what your eyes actually do as you read the letters, okay? Then what we're going to do, and then if your partner is going to watch what your eyes do while you read, and then you're going to switch. So if you're the observer first, you read out loud, and I want you guys to just tell me what you notice when you watch each other's eyes read, okay? So there you go. Here. You can pick any row. Okay, you ready? So I'm going to let you go ahead and just read whatever row is most comfortable for you to see.
I'm barely talking.
Okay, you want to move closer, or that be?
No,
okay.
I'm a good guesser.
Okay.
B,
Okay, so now I'm going to read it, and what we're going to do is I'm going to sit here. You just turn around and watch me, okay?
So what am I looking for?
Just pay attention to what your eyes do when you're reading the letters, okay? So can you see my eyes?
Uh-huh.
Okay. D-E-F-P-O-T-E-C. Do you see them do anything?
No.
Okay. We'll come back to that, okay? Well, yes, your eyes move. Okay. Okay, it's not a trick question, okay? So now, normally when I do this demonstration, I don't have a lot of patients with nystagmus, but for those of you without nystagmus, did your eyes move? No. And with a patient with a nystagmus, of course, you're going to have movement, but for the most part, they just looked straight ahead, right? Okay, now, you were handed slips of paper with a paragraph on them. You actually really don't need one per person. You're going to partner up again for this, and what you're going to do is you're going to read silently to yourself that paragraph. What I want you to do is pay attention to what your eyes do as you read the paragraph and have an observer watch you, and then switch places and see what you notice. All right. And you can just read silently to yourself. Okay, go ahead. Can you see that? Okay.
Your eyes have to read from left to right. Your eyes also must focus to keep the correct clear. What you may not realize is that your eyes also have to converge.
And I'm going to stop you right there. You don't even have to read. And you don't even have to read the whole thing. It's just read like the first couple of lines. Okay, I want you to watch my eyes now, okay?
Yeah, going back on board.
Okay, very good. You got it. A+.
I did, yeah. That's weird.
Yes, that's partially average. This is why when I first saw my baby period, I thought the drug that she was like, the precursor of reading.
Nope. Okay, has everybody had a chance to do it? What do you... You guys already have done this, and you're still... Okay. What did you guys notice when you were reading? Do other people need to still have a chance to do it? I'll let you go. They're moving, right? The typewriter effect. So they're going from left to right and from the end of the line all the way back to the beginning of the next line, okay? So when we, just by show of hands, when you read, do you lose your place, skip words, skip lines, have to read with a finger? Anybody have to do that? Okay. Anybody get any double vision or feel like the words are moving when they read? Okay, anybody get blurry vision when they read? Okay, so the point is, when we read, our eyes move from left to right, and from the end of the line, they move back and forth. The print has to say clear and single, avoiding that double vision. And then, so the point is, when we're testing for 20/20, so when I had you look at the eye chart and you just read the letters to me, is that test going to tell me what I need to know about a kid's eyes when they're reading? It's not going to tell me anything about that. So, is testing for 20/20 sufficient? No. The typical vision screening using the Snellen eye chart only identifies 5% of vision problems. Now, this goes for any type of vision problem you can think of screening. So I'll have parents, I'll say, is this your child's first eye exam? No, they get an eye exam in school every year. That doesn't count. That's a vision screening. That's not going to count to catch a lot of these vision problems. So we can't rely on testing for 20/20 to define good vision or poor vision, which again, if we're measuring with nystagmus, if you have a child whose visual acuity is 2200, that tells me one component of that child's vision. It doesn't tell me everything else about that child's vision. So there's more you have to do. Hence the term functional evaluation. We call it a binocular vision evaluation, but it's checking for more than just reading the eye chart, which is where I think a lot of eye doctors stop because they feel like there's really nothing else that can be done. So how much can you see? It's probably not going to get any better. Here's your prescription. See you back in a year. Okay, so what do we do with all this? Okay, just to kind of review the things that I've thrown out there. We've talked about, the difference between a developmental optometrist and other eye doctors. That vision is the dominant sense. It has an impact on vision. We've reviewed the developmental milestones. We've talked about what the definition of vision is, and we go from there. So when we were talking about reading, I'll do this. We'll go here. So what can as an optometrist, as a developmental optometrist, what are things that we can do? In the lecture about vision therapy in the last hour, she touched on this, and I just want to reiterate it. So one of the things we can do is prescribe prism to shift a null point. So do you guys know by show of hands, who knows what prism is? Okay, so what a lot of you do, but for those of you who don't, I'll explain it. So prism shifts things. So if you were to look through a prism, it can shift it up, down, left, or right. The example that I'll use is I have a patient, about a 10-year-old boy with nystagmus, and his null point is when he has his head up in vertical gaze. So he walks around like this, and especially if he needs to see something, the more he concentrates, the more that head shifts down. I gave him base down prism in his glasses. So what that means is it shifts everything up for him. So when he's walking around, instead of him having to do this to see, everything is shifted up in his glasses naturally. So it lessens the null point for him. It moves everything to his null point so that his head doesn't have to move as much. That I did, mainly to help him function better in school and other things like that. Is just, he was so young when it all he was being treated, but just I think it's a more comfortable way. Even if your null point is in, you can shift prism in, you can shift it to the side. I mean, that's a great thing about prism is you can put it wherever you want. Not all eye doctors are comfortable prescribing prism. That would be something you would talk to before you even walk in the door is, I think my eye might need prism. Does the doctor test for prism? I know a lot of doctors that are terrified of prism and they don't want to have anything to do with it. I love it, but I've had the additional training in it, so it's a tool. For a lot of doctors, it's their enemy. So that's something to ask when you're, potentially scheduling an appointment. Another thing you do is consider contact lenses. So when we make glasses, if this is the lens, the center of the lens we measure, we line it up in front of your pupil so that when you look through your glasses, you're looking right through where you need to. Well, if you have nystagmus, your eye is moving, and so you're not looking through the proper part of the prescription. The beauty of a contact lens is it moves with your eye, so you're always looking through the part that you need to see. So we can do that with soft contact lenses. When I was in school, they really encouraged us to consider hard contact lenses for nystagmus patients because they can feel them in their eyes, and that gives them sensory feedback that their eyes are moving. I've done it on a few patients. I prefer soft contact lenses just because I see a lot of young kids with it and it pops out of their eyes very easily. Yes?
What would be the benefit of having them feel that their eye is moving?
Sensory, that's what I was going to say. It's feedback that their eyes are moving, and then I'm like, and then what? They make their eyes stop moving. But, it is that's the theory behind it. That's why I said I did it in school, didn't really see much improvement with it. But that is something that as eye doctors we are trained to do. So the idea is give them hard contact lenses. So that may be something that you can try. I mean, it doesn't hurt to try and see. I just don't like fitting hard contacts on little kids. So in real life, outside of school, I do more soft contact lenses than I do hard contact lenses.
So you can put prism in on contact.
You could only put prism in a hard contact lens. So if we want to do prism, we're back in a hard contact lens for that. Yep. And every patient is different, just like Dr. Lung was saying in her lecture. Every patient's different. So it's a conversation about what are your expectations? What can I do? What is your chief complaint? What did you come in here needing help with? So, it's all about what can I do to help, and everybody's going to be different on what they need. We do vision therapy. There's a fantastic lecture last hour about vision therapy. So that's all I need to say about that because she did a great job. That's what we do in our office. What she really went over was, okay, remember when we were reading that paragraph? I'm going to kind of go back about what she's treating for. So that movement of your eyes going from left to right and then from the end of the line all the way back to the beginning of the next line, we call that tracking. That's an ocular motor skill is another term to use for it. So she was talking about treating tracking problems. If you have a tracking problem, you lose your place, you skip words. Patients with nystagmus, they're going to have a tracking problem. So I think it's about not only improving their tracking skills, but then also teaching them how to, basically it's the repetition of practicing those tracking skills and that motor memory and that neuroplasticity, the idea of the more you practice, the better your brain will get at it, can really make reading easier for somebody when they're practicing that over and over and over again. Now, back to the reading thing, I wanted to show this to you guys, and you may just have to turn to your partners again. What I want you to do is you can look up at the chart here, and then I want you to look back down at the paper, and I want to see if anybody notices the difference in where your eyes are pointing. Okay, so if you look far away, what are your eyes doing? They should look like they're straight, right? Okay, when you switch to looking up close, does anybody see a difference in how your eyes are pointing? They go down, but they do something else. They come in. Anybody see that? Okay, they go down and they go in. That's called converging, okay? So converging is eyes turning in, and then diverging is eyes going straight, not out, but just straight. So when we're checking, I'm sorry?
What do you mean coming?
They turn in. They literally turn in. Yeah, crossing. Your eyes cross. I mean, they don't totally cross unless you have an but when you look up close, your eyes are supposed to converge. So we check for convergent skills. We check for your divergent skills. You can have convergence insufficiency, other things like that. And so she went through, that's when she was talking about the Brock string and that other barrel card that she had in front of her. And that is your eyes work together to do that. She talked about binocularity, and it's your eyes work together as a team. So working on a patient's ability to converge. I see a lot of kids, obviously. I keep saying child and then correcting myself. But anyway, your ability to converge is huge. It also helps with fatigue. And so making those muscles stronger let you read for longer periods of time. Some kids are patients that have convergence problems will get double vision when they read. They'll cover one eye when they read. And so those are all things that can be treated in vision therapy. A third thing that she went over was focusing problems. And I don't mean like attention focusing. I mean literally your eyes have to focus like a camera to see the print. You can strengthen the muscles of the eyes so that when you read, you have the strength to physically do it. So those are all things that we do in vision therapy. Does that make sense? Okay. Some common vision accommodations that I make for school, obviously larger print. I prefer print without a serif on it. Serif is when the line gets thicker at the bottom. I like a cleaner print for patients that have any type of reduced vision. High contrast print and pictures. I want white paper, black print. I want, if there's pictures, it needs to be in primary colors, no pastels. It needs to be large enough for the child to be able to see what it is that they're doing and not get points off because they physically can't see it. I'm a big fan of less visual information on the page. And what I mean by that is, even if you just look at my notes, this is a lot to put on one page. And so to a patient who has a tracking problem, any type of vision problem, it becomes overwhelming for them to look at all of this. So I will tell parents, just take a white piece of paper and cover up half of it. And that way, the input, remember I talked about vision to 70% of learning, and if you're overwhelming the visual system, you're going to start having problems. So cover half the page. Ideally, I would have, if it's 1 page of information, I'd have it blown up, separated, and spread out on 2 pages of paper. It's a lot of work to do, but I think the less information on a page, the better. You can accomplish that. Some kids, will say, well, let's read with a finger. I prefer a note card or something that's going to block more lines of text than just a ruler or something like that. I want to block out a lot of that. Obviously, sit in front of the classroom, oral testing in place of written. I don't want a kid to get a poor grade on something because they literally didn't see the question. So I have a lot of teachers who are willing to test kids orally. Yes?
Sorry, you may or may not be about to say this, but obviously people with nystagmus have a favored eye orientation. It's very important where in the class. Yes, absolutely. They have to have that choice.
Yes.
Otherwise they're going to be looking against them.
Yes. That is very true. Kids need more time. And then I ask for a decreased amount of homework. And the reason I ask for that is it takes them longer. It's physically more exhausting for them. What may take a kid 20 minutes to complete may take a patient with a vision problem twice as long. So cut the homework down. Now, I ask for a lot of these right before we put a kid in vision therapy, and I'll say these are temporary modifications. Some of these you will not have to have forever. The increased font and other things like that you may need, but decreased homework, I'm not asking that for the rest of their lives. I'm asking for decreased homework while we're doing vision therapy with a child because I've got homework I need them to do, and so let's try to lighten the school load so we can get vision better. Any questions on that? Okay. All right, I want to talk about occupational therapy. Has anybody heard of occupational therapy? Okay, yeah, you two have. Okay, I'm a huge fan of occupational therapy, and I was, again, back to when I was trained, I don't even know what this was. They were like the handwriting people, I think is all I knew about them. But as I started to see real kids and real patients and realize there's more to this, actually unfortunately how I found out more about occupational therapy was I had kids in vision therapy who were not getting better. And I'm like, we just keep practicing tracking and they're not getting better. What is wrong with this kid? Then I learned about the testing that we can do. And you guys can look at it if you want to, but there's a test that I got for my staff to give to children, and it goes through that hierarchy of development. So it goes through all the gross motor stages, it goes through all the fine motor stages, and then it looks at visual perception, which is how your brain processes visual information. When they're in the exam room with me, I'm checking tracking, converging, focusing, visual acuity. So those ocular motor skills, that's what I'm checking as the eye doctor. What my therapists will do in the practice is they'll screen the gross motor skills, they'll screen the fine motor skills, and the visual perception skills. So when I meet with a family, we've got everything. We've got from beginning to end, everything visually, what's going on with the child. If I see weaknesses in gross motor or fine motor, I'm going to make a referral out for occupational therapy. And this is my choice, not every doctor does this, I prefer a patient to go through occupational therapy before they go to vision therapy. Sometimes I will flip that around. If I've got an old enough kid who it's having a profound impact on their academics, we'll start VT, vision therapy first, and then we'll go back and do occupational therapy, and we may come back and do vision therapy again. But I refer out for occupational therapy all the time. I have had kids that I've referred for occupational therapy cut their treatment with me in half. I've had kids that go to occupational therapy, they don't even need vision therapy when they're done because all the underlying problems that were causing this vision problem were fixed, okay? So they are specialists in fine and gross motor development. There is some overlap between our two professions, so they will work on tracking, not like I do. Mine's way harder. Theirs is much more basic. They do work on visual perception. Mine's way harder, but again, they will start a lot of that foundational stuff. They also specialize in the vestibular system. Has there been much talk this weekend about the vestibular system at all? You talked about the vestibular system? Okay. I'm just going to say a little bit about it, okay? And bear with me because I'm going to butcher this, but I've been to vestibular lectures and I walk out with a headache because it's a lot of information. But the point I want to make is, okay, here's your eye muscles, the 6 extraocular muscles, okay? So you've got the superior and inferior rectus. This moves the eye up and down, okay? Lateral rectus and medial rectus muscles, it moves the eyes horizontally. And then you've got the superior oblique and the inferior oblique, and this rotates your eye, okay? Your vestibular system, the semicircular canals, there is a vertical component a horizontal component and there is an angular component, okay? The vestibular system and the visual system are linked to each other, okay? And honestly, like, we're just now realizing this. So this is kind of blends it all together. I don't know how much this picture actually explains things, but the idea is, you know, what you're doing visually has an impact on your vestibular system. So that was something that I mentioned, you know, if you guys don't mind me saying. I mean, I was concerned about James's vestibular system because visually he actually does pretty well, but there could be something going on with the vestibular system. I'm not an expert in the vestibular system. I know occupational therapists who are, and so I made a referral out for occupational therapy to look at, is there anything we can do to help stabilize the vestibular system along with gross motor, fine motor, visual motor, and other things like that. Does that make sense? I think really all you need to know is go see an occupational therapist, mention vestibular, and you should be fine, okay? As an aside, I think it varies by state how you can get in to have an occupational therapist do an evaluation. In this great state of Louisiana, I can write orders, but legally, it has to be the pediatrician that does the orders. My experience has been, if you, as a parent or as a patient, call and say, my eye doctor wants me to see an occupational therapist, your physician is going to laugh because vision and occupational therapy don't make sense to them. So I usually just say, hey, just tell them, hey, we've got some concerns about handwriting or coordination. Leave the eye doctor component out of it. Just say we've got some concerns about whether it's motor development, gross motor, fine motor development, and see if your pediatrician will give the green light to do, you know, an occupational therapy evaluation and keep me out of it. I've had kids be denied services for occupational therapy because I was the one making the recommendation for it. So I don't want to see that happen. Within occupational therapy, there's something called sensory processing disorder, which we're almost to the video. Has anybody heard of sensory processing disorder? Okay, I had never heard of it, again, until I started seeing live kids that I was responsible for. And the idea is, and I'm going to show you this video, is basic. It looks like I drew it. I mean, it's just, the artwork is very basic, not to be condescending, but it is, I think it spells it out very well. But again, for a child, let me see. Oh, there we go. We're there. Okay. So for a child with any type of vision problem, again, we're making a referral to occupational therapy to possibly diagnose and treat sensory processing disorder. Again, remembering vision is the most dominant sense. If you have a problem with vision, how is it affecting the rest of your senses? So you can hit play, yes.
Some kids are really bouncy, can't sit still. Some kids aren't very coordinated. Some see food as a pile of toxic goo that hurts their mouth, jangles their taste buds. School might be a mysterious place where things don't make much sense. If it sounds like you may have sensory processing disorder, and we're going to explain it here. Your body has 7 senses: vision in your eyes, hearing in your ears, touch in your skin, taste in your mouth, and smell in your nose. And you have 2 movement senses, your muscles and your sense of balance. In sensory processing disorder, these senses don't communicate right with your brain. Think of the nerves connecting your brain and senses as a set of roads. Those roads should be smooth superhighways so that the senses and brain can communicate fast. If you have sensory processing disorder, then some of your roads are bumpy and rough. You can also think of the senses as having a broken volume control.
I see this a lot.
Your senses too strongly. If the volume is too low, you won't feel sensation at all. In fact, you'll want more. Some kids overcome these problems as they grow older. Others need help. Help is usually occupational therapy, and it's fun. Occupational therapy helps
Sounds looks like fun.
connections between your senses and your brain. The more you do, the stronger and smoother they get, kind of like paving those roads. After a while, you'll learn to slow down and sit still, to pay attention, to eat, to be comfortable and happy doing movement. It takes time. There's homework, too. But the more you work at it, the better it gets.
I think that's hilarious. Like, who would claim that animation? But anyway, the reason I bring that up is, again, just going back to, if vision is the most dominant sense and your sensory system is supposed to combine all 7 of those, if vision is affected, it stands to reason that it's going to affect the other senses. What I see in patients who have poor vision is they tend to be sensory seekers, which means...
I wanted to do a tutorial for kids, brushes and solutions as we call it in this household. They're quite skilled.
Who is trying to steal my thunder? No, I'm kidding. Anyway, sensory seeking kind of kids. So I get the kid, usually, it can, again, they can be normal vision or nystagmus or whatever, but they're sitting in my chair and they're moving like crazy in the exam room. And it's because they can't look and get feedback. They have to get it back from sensory motor input of some kind. And so what is great about occupational therapy is they're great at combining the senses. And when I have a patient with nystagmus that I refer out, I always want to talk to the occupational therapist and say, okay, here's why I sent him out and here's what I need you to do. And of course, it's always reinforcing lots of vestibular. So you could maybe not tell in the pictures, lots of swinging, lots of standing on unstable surfaces so that you're stimulating the vestibular system while doing visual skills at the same time. So and I do the same thing in therapy in my office, my staff knows a child is never standing on the ground. They're sitting on an exercise ball, they're standing on a balance board, they're on a trampoline. We are always stimulating their vestibular system while we're moving their eyes at the same time. I think that's basically it. Looking for a doctor, this was brought up in the other lecture. COVD.org is where you can find a doctor. Not all doctors that do vision therapy are members of that. I'm not a member, neither is the other doctor that presented. And that's, there's a lot that you can be a member of. But that is a good place to find a doctor. Simply calling and finding out who does vision therapy is another way to find out. SPDfoundation.net is where you can find OTs that specialize in sensory processing disorder. Most in-hospital type OTs do not do sensory processing. It's usually private clinics that do sensory processing therapy. And then there's my email address. So if you have any questions, feel free to email and ask. We went a little long. So does anybody have any questions for me at all? I'm good? Oh, do I have to keep talking? No, okay. No, but if anybody has any questions, that's it. Yes?
I just wanted to point out something. I periodically assess children
Uh-huh.
clinically for their optometry. One of the confusions that arises, particularly with parents, is this use of the word tracking.
Yes.
Because for scientists, tracking is this.
Yes.
Whereas, as I know you know, reading is a series of saccadic.
Yes.
Yes. And so it's just it's a confusion that's permeated the whole clinical world. We actually did a study and asked optometrists and therapists and educationists, and they all had a different definition of what tracking is. So I just thought it might be worth, because a lot of people, when they hear the word tracking, they immediately think of this.
Yes.
I know you know.
Right. So pursuit is just you following a smooth, right, and then a saccade is the shift back and forth. Okay.
It's called smooth pursuit.
Right. So when you read,
here to here is just a saccadic.
Right. So reading is actually saccade, big saccade, big saccade. So, but what I will have, it's funny you talk about basically define tracking. When I talk to occupational therapists and I say, what do you mean by tracking? It's always this, the smooth pursuit. And that's why I was saying mine's harder. What'd you say?
A lot of them, as a result, only test this. They don't test the reading, which is probably what the educationalist had in mind when they...
Right, exactly. And that's why I was saying there's overlap, because they're going to work on the smooth pursuit. If I get a child in my office and they cannot do a smooth pursuit and follow me, they are going to occupational therapy, because they don't even have the most basic of eye movements. If they can do that, then maybe we can get a saccade out of the kiddo. But yes, when I talk to OTs, they're like, what do you mean by saccade? And I'll show them what we do for therapy, and they're like, that's way harder than what we do. But just developmentally, saccades come after smooth pursuits. So our vision therapy is harder than occupational therapy. So yeah, you bring up a really good point.
We've done a lot of work on the pursuit in young children, and the finger is often not sufficient, as I'm sure you know.
No.
Kids flip the finger and just say, well, that's interesting, follow that.
Right.
But we use a lot of little animated things that flash with light and
Yes.
things like that. And then and on the screen we use morphing analytics. And basically the kids actually
They're scared into pursuing. No, I'm just kidding.
They're tiny.
Yes.
The kids
Yeah.
will even verbally report, oh, it's a bear, it's a lion. It's a
Yeah.
this, it's that. So you know they're paying attention.
Yes.
So
Yeah.
as you know, attention is a big issue.
Yes, and I should have brought my wand that I use. It's a cube, like a dice, and it's got little stickers on it. Okay, and I'll say to the child, the first sticker is a house, and it's got a red roof and yellow windows. And I'll just say, "What do you see?" And I'm moving while they're in. So it's a house. What color is the roof? What color are the windows? And so I'm asking questions. They have to be visually paying attention. OTs will do a finger, or they'll do the tip of a pen. How exciting is that? I mean, so it's all again, but that's okay. If they're finding problems with just that, then obviously the problem is deeper, and so that's where they need to start with that. Any other questions? So, Monday, find a developmental optometrist and an occupational therapist. Not saying you need to have either one of them, but they can probably give you a lot of insight and just different information and shed some light on some different areas for you guys. Okay? All right. Thank you.